Hello friends, today we are going to discuss regarding echocardiography findings in a patient with aortic regurgitation. Number 1. Structural evaluation, which may include aortic wall morphology. So, in aortic wall morphology, there can be bicuspid aortic wall, prolapse, rheumatic affection of aortic valve, calcification. It will basically help us to identify regarding the cause. Then aortic root disease. So we have to check if there is dilatation of aortic root, if there is dissection flap, or if there are Marfan features which may reflect aortic root disease in a patient. Number 3, LV size assessment and function assessment. So in chronic AR, there may be dilatation of LV, and in acute AR, we may not find dilatation of LV. It will guide us to assess regarding chronicity and compensation in a patient with aortic regurgitation. Now, we will go through color Doppler findings. With the parameters that we are going to look at, it may include number 1, jet size upon LVO2 ratio. So if jet size upon LVOT ratio is less than 25%, we label the patient to have mild AR. If the ratio is between 25 to 64%, we label the patient to have moderate AR, and if it is more than 65%, we label the patient to have severe AR. Then the second parameter is jet direction. So if the jet direction is central, then it points toward cusp pathology, and if it is eccentric, it points toward prolapse of the cusp. Number 3, vena contracta width. Vena contracta width is basically the narrowest point of the regurgitant jet. So if it is less than 0.3 centimeter, we label the patient to have mild AR. If it is between 0.3 to 0.6 centimeter, we label the patient to have moderate AR. And if it is more than 0.6 centimeter, we label the patient to have severe AR. Now, we will look at continuous wave Doppler finding across aortic valve. So there may be AR jet density. So in severe AR, there is increased AR jet density. Complete filling indicates severe AR. It reflects increased regurgitant volume, which may occur in patient with severe AR. Then pressure half time. So if pressure half time is more than 500, we label the patient to have mild AR. If it is between 500 to 200, we label the patient to have moderate AR, and if it is less than 200, we label the patient to have severe AR. Then diastolic flow reversal in descending thoracic aorta. So it is assessed by pulse wave Doppler in descending thoracic aorta, which is usually obtained at suprasternal view. So if there is mild, brief, early diastolic reversal, it points toward mild AR, and if it is complete holodiastolic flow reversal, then it points towards severe AR. Now we will go through assessment of LV size and function. As we have already discussed that in a patient with aortic regurgitation, there is chronic volume overload of LV, and over a period of time there can be LV dilatation and LV systolic failure. And it will also help us to guide regarding the need and timing of surgical intervention. So if the patient has severe AR and patient is symptomatic, then the surgical intervention should be considered. If the patient has severe AR but the patient is asymptomatic, then we should do regular echo in such patient. And if there is reduction in ejection fraction that is less than 55%, or if there is increase in left ventricular and systolic dimension more than 50 mm, then surgical intervention should be considered. Thank you.